Hi, I'm Dr. Larry Eichenfield from the University of California, San Diego, and Rady Children's Hospital.
And I'm Dr. Dawn Eichenfield. I'm also from the University of California, San Diego, and Rady Children's Hospital.
And we're going to have a little discussion about topical JAK inhibitors in pediatric dermatology practice. And so Dawn, I'll start off asking you, let's go disease state first, atopic dermatitis. Topical JAKs in practice, how do you find them useful? And we'll come next to like, how do you counsel patients about them and about safety issues?
So I think topical JAK inhibitors work very well to help with atopic dermatitis flares, and I also use them as keep away. For example, if the eczema is done flaring, I'll still keep on telling patients to use the topical JAK a couple of times per week to try to keep that eczema from coming back. I use it, I'll use it for different parts of the body, on the face, on the hands, anywhere on the body, just because there's no side effects. The side effect profile is so good, there's no side effects of thinning of the skin or a cause of telangiectasias or anything like that.
So talking topical ruxolitinib, you know, in the core ruxolitinib atopic derm trial, it was BID application for 8 weeks, but then they went into this 1 year
That's true. The open label
non-continuous use
extension.
where they could use it as needed, and it gave this imprimatur of safety. So at least on label, 12 plus can be used steadily or as needed. 20% body surface area limit, which I actually keep to.
I do too.
Yeah.
And it's actually 20% body surface area is a lot of body surface area.
Sure, that is 20 hands of
Yeah.
eczema. It's pretty, often, you know, I mean, 10% and higher can be considered to be category enough
For severe,
and for systemic therapy. So, so one of the questions that I asked you, but maybe I'll answer it, is sort of what do I do about the counseling with patients for topical ruxolitinib in particular. And, you know, the good and bad is that topical ruxolitinib was the first JAK inhibitor approved for a dermatologic condition, right? It was approved for vitiligo and atopic dermatitis. And it got the full JAK class label, you know, coming from tofacitinib data. But it's been a long time since it was approved to now, at least long enough that I think we've become really comfortable with the data set. So first, my interpretation of the data set is that used correctly, you know, 20% limits body surface area for atopic dermatitis has a ton of safety with it. So basically, I give a very short discussion. I don't want patients to see boxed warnings having not heard that they might be there, but I basically say, hey, there are some warnings that are here in relationship to this drug, but they're really based upon other JAK inhibitors with oral therapy. So if you use it the way we say, you really don't have to worry about those. And that's sort of my practical approach.
I totally agree. I also tell them that they have done studies looking at blood levels of ruxolitinib, and if you use it as indicated in the label, you're pretty much not going to see blood levels, and I think that is also very reassuring to families when they're using the medication.
Now, whether I'm on the podium or talking to my patients, I love the phase 2 data. Right now, we have a nice set of non-steroidal agents for atopic dermatitis. We only have one study that compared a non-steroidal with topical corticosteroids, and that was in the phase 2 ruxolitinib study. And ruxolitinib's a cream, so it was compared to triamcinolone 0.1% cream used BID. And they didn't do the 8-week time period, they did it at 4 weeks because you didn't want to treat people beyond 4 weeks with a topical corticosteroid. And basically, the ruxolitinib outstripped the success of our standard mid-strength topical corticosteroid in multiple outcome measures. So I sort of sometimes mention that to families. My families who are experienced with use of topical corticosteroids, I can tell them, you know, it's like our triamcinolone is sort of mid-strength and higher, but without being a topical steroid. And so I think that sort of explains what I expect to get out of it. And often they're very, you know, we get this incredibly positive feedback about its efficacy, you know, because it has tremendous efficacy for a non-steroid.
And it's also very impressive when you can use it on parts of your body where sometimes you would get like burning sensations when you're using other non-steroidals on that part of the body, like eyelids, like eyelid dermatitis, or on the face, or even on inflamed skin. I feel like patients have very good feedback about what they're experiencing when they're using the medication.
Okay.